Thank you, PA. It's glad to be here. Really nice to attend a conference. Sage had working to make things happen. Let's see. So, what I thought I'd talk about today is something that is really rapidly evolutionary and really a lot of fun. It's the molecularly targeted radiation therapy. That's another word for theranostics, or we could talk about radioligand therapy. But doesn't matter the name. The concepts are actually pretty simple. When we go forward and see the concepts, it makes intuitive sense. Patients get it immediately right away. They absolutely love this concept, and they sometimes want it before it's even ready to get it. So when we go through, thinking about prostate cancer as a whole, we've always had, radiation, surgery, and hormone therapy, and chemotherapy. There's chemotherapy since the mitochondrial days, 1993, 94. So we've had those kind of building blocks for a long time. What's changed is actually a lot. Genetics are now part of our routine care, both the somatic genetics as well as germline genetics, recommended by NCCN for virtually everybody with advanced disease today. Microimaging, things like this, that has totally revolutionized the way we look at disease. Artificial intelligence is coming with something called AI that looks at pathology and makes projections over the future of the patient to predict hormonal sensitivity more. Targeted therapies, things like the PARP inhibitors as well as the PD-1 inhibitors are now approved in certain selected settings. Immunotherapy in the selected setting. One of the immunotherapy that's exciting right now, I'm not going to really talk about it. We call the T-cell engagers, things like pasritamig, binding TLK2, like our number of targets, and opposing that with a CD3 and activating the immune system selectively, and you can't really do microenvironment. Very interesting. And then molecular target radiation, which I'm going to focus on. So, lots to talk about. For diagnostics, it's such a simple principle. You want to be able to see it, and then you treat it. And I say I love it because it really sort of changes the paradigm for how we approach the disease. The key elements are, on the cancer cell, you need a target. And that target should be expressed on the cell surface, ideally. And it should be selected in a reasonable way so that the binding to this cancer cell has specificity over and above that of the normal tissue. Now, when it gets a little complicated is when you look at the short-term scans like we've got in 68, you're looking at a 1 hour tension. And you can get deceptive findings because the washout that occurs in some of the normal tissue is not seen unless you do what we call dosimetry along the voluntary range. You need a ligand that environment that cell surface. You need a linker that is going to be able to attach the radionuclide into the ligand. By the way, you don't always need that because sometimes you can use like F18 and attach it with a halogen directly to the molecule cell. And then, depending whether or not you're going to have a PET imaging agent like PSMA, gallium-68, or F18, used for diagnosis. The therapy is therapeutic isotope, and that's something like position or activity. So, the concept is you want to see it, you want to treat it. And for molecular targeted isotopic therapy, which is one of the terms that I use, there's a whole diversity of potential targeting molecules. There's small molecules like PSMA-617, there are bicycles that are being looked at for Nectin-4, there are a whole variety of peptides, some of which are in use in prostate. Various antibodies, Aptamers is now an Aptamer company that's pushing forward. And there are also diversity of isotopes. So a lot of different ways to bind the cell and a lot of different ways to bring the isotopes, all of which are different and depending on what sort of potential you're looking at. One of the reasons I really do enjoy working in this area is we're dealing with cellular heterogeneity to some degree in advanced cancer. It's just part of the problem we face. Not all the cancer cells are the same, not all of them express the same target. And when you're using this radioligand approach, you're actually creating something called crossfire because the lead particles are going to be going on for about a millimeter or so pretty controllable radiation, but you don't have to have the target expressed on every single cell. You can actually bind to one cell and kill another that's adjacent, plus you alter the microenvironment. And the microenvironment includes things like the vasculature, the supporting stromal structure, which is important for the cancer cell growth. And this ability to generate crossfire helps to overcome the heterogeneity that I think really contributes to the success we have with these type of approaches. The smaller tumors, however, once the tumors get small, you don't generate enough energy in the cell that you bind to, so single cells are not well targeted in this approach. Maybe with an alpha, maybe with an OJ, it's a little discussion. Or for the betas, which are things like the tissue of our workforce, you need a group of cells together in order to generate the crossfire and generate the cell good. This is an important paper because it's pivotal for the FDA approval. Victo and in the journal a couple of years ago, just going through some of the data, which you may not be familiar with. These are patients who really were very, very end of life. They had already had at least one taxane, maybe two, but 40% of the patients had had two taxanes. They had to have at least one FDI, the abiraterone insulin typically, and often two or sometimes even three. And they basically had exhausted their therapeutic options. So coming into this really late stage patient, the patient's randomized between just the standard care, the docs could do whatever they want except for chemo, and plus or minus lutetium. And they had two primary endpoints, both PFS, progression-free survival, and overall survival. The patients were selected in the PSMA PET scan if you want to make sure the target's there, and 87% of the time the target was there. So we ended up actually scanning in this particular trial, slightly over 1,000 patients, about 1,003 patients, and 87% met the PSMA PET criteria, which is PSMA PET positive by the liver in metastatic lesion. There were exclusions for those who had a PSMA PET negative finding who was seen on conventional imaging. The most common one is the liver. The liver develops metastases, and they're not always PSMA PET positive. And the liver lesions are a common reason for exclusion. If you're treating somebody with Pluvicto, PSMA 617 tissue, and have liver lesions and they're PSMA PET negative, you probably ought to be doing something else. Anyway, we wrote this forth. Here's the overall survival on the left and RFS on the right. Both these were substantially positive. Hazard ratio is 0.62 and 0.40. And there were some unequivocal findings the FDA basically like what we saw, particularly with the overall survival and that led to the approval. There are a couple of things that were interesting about it. These are subset analyses that I'll share going forward. One is that the PSA decline at any time before the 12-week point. So the second, this is given every 6 weeks. So your first dose, then your second dose at 6 weeks, and then we give your third dose at 12. So before that third dose is given, if you look at the PSAs, you can really stratify the outcomes very quickly by looking for PSA declines. Those people without PSA decline are not going to do well. Those people who do PSA decline are going to do very, very well. So it's just a simple biomarker going in, and I take advantage of the PSA 10, 11 weeks, and I kind of know what's going to happen. The other thing that's interesting is to be able to look at the degree of uptake on the PSMA PET scan. So there's something called whole body SUV mean, which basically looks at the PET uptake and quantifies the degree of uptake that you see on the PET in the metastatic regions. And the more uptake you see, the better the patient is going to do, because you have better binding. So the better binding translates into essentially more effective therapy. So this is an image-based biomarker, in addition to the other biomarkers we use, like circulating tumor DNA, etc. So image-based biomarker is actually important, and I pay a lot of attention to the degree of uptake that we see in the scans. This is another way of looking at the degree of uptake. There are two elements here on the top. You see the RPFS, and the bottom we see the OS. The print's a little bit small. We're looking at the SUV being cutoff, and we're going all the way on the OS from 7 up to 28 is over there. And the hazard ratio that is shown, lower hazard ratio, means that there's a better outcome. And you can see this sort of linear relationship between overall survival and the SUV mean that is done as a baseline PET, so that's good. On the right-hand side, the right-hand column, where you see kind of the multiple colors, I'm colorblind, so always get confused. I think on that's really an easy one. Hopefully there's one that's getting initially kind of large and it gets smaller and smaller. Those are the number of events that occur over time. And the number of events that occur over time diminish as the issue goes up, meaning patients die basically. So that's important. This is one from Mayo Clinic that we put together in the Mayo Clinic series where we just looked at those people with liver metastasis. These are patients who got treated liver metastasis to colon, by the way, with almost any therapy, including the PSMA mutation. So liver mets are bad. Always try to get rid of them if I can. It's just one of the important things. So we finished up the initial trial. We learned a lot. We got an FDA approval, but there are a lot of things we did not know. I think it's important when we talk about trials, not only about what we do know, but what we do not. And here you see about optimal patient selection criteria, then question mark. We drew a threshold at uptake in greater than liver, but the truth is, I've now shown you that the SUV mean as it goes higher, the patients do better. And that's something that we can put into the selection criteria. Often dosing schedule was not explored. We used a dose of 200 millicuries or 7.4 picomolecules, Q6 weeks times 6. It hasn't been adequate dose and schedule exploration. We're doing that now with other agents. I'll simply say that there are better doses and better schedules. For the mechanisms of resistance, we're still struggling with that. How do we best monitor and detect response resistance? Well, we know about PSA, of course. But we don't have all the data on the scans yet. We need repetitive scans in order to be able to show. And I'll tell you the total tumor volume is a manuscript in press right now that I'm part of, looking at total tumor volume on the PET scans. That is really, really important. So if you start with 500 cc's and you drop down to 100, that's really important. If your volume goes up, that's really bad. Simple parameters. It takes a little bit of AI to do it properly because you're trying to integrate all those number of lesions. You may see 49 lesions, and you ask what is the total tumor volume within the metastases. So you need to integrate that. It's not super easy to do it without some AI, but with the AI, it's quite easy. How do we add particular treatments or combinations? That's a big, big issue. I'll come back to that. Pre-chemotherapy space, castrate-resistant space. All these issues are yet to be determined, but we do have now an FDA approval in the earlier stage. This is not an FDA approvable trial. This is out of Australia called INSAP. It's interesting to me because the best hazard ratio ever shown in the history of castrate-resistant prostate cancer is this trial. Hazard ratio is 0.549 or 0.55, I think they rounded it off to. And it's a pretty solid trial. It's just castrate-resistant. And everybody knows that enzalutamide is a very effective therapy for those with castrate-resistant disease. And here you have enzalutamide as a control arm, and you have enzalutamide plus lutetium in the experimental arm. And the hazard ratio came out strongly positive. I can't see the numbers, but I know it. There it is. Yeah, 0.549. You can see, and this is really strongly positive, suggesting that maybe synergizing with the hormonal therapy could be important, at least in this setting. But remember, these are patients, which I didn't explain, that had not been pretreated with an ARPI, no abiraterone pretreatment, no enzalutamide pretreatment. This is just ADT. So it's a little bit antiquated today, where almost everybody gets an ARPI up front, right? Darolutamide, apalutamide, enzalutamide, abiraterone, all FDA approved in the upfront setting. So I have a bunch of important phase 3s. The PSMA-4 is now FDA approved. SPLASH was presented at ESMO 2024. Eclipse is announced as positive, but we haven't seen the overall survival data. I think we might see it later this year, maybe ESMO, we're going to see. I'm going to go over the PSMA-4 because we do have an FDA approval. That's from the Lancet paper that summarized that phase 3 trial. This is in what we might call the taxane-naive space. So these are people who had an ADT and an ARPI, and then were being randomized to a second ARPI versus the lutetium. The FDA would not allow us to use combination therapy, which is very irritating. But anyway, we do have the FDA approvals starting about a year ago, March 28th of 2025. Very similar design, confirmed progressive metastatic CRPC, castrate naive, being able to have PSMA PET positive lesions, and had to be greater than liver to be defined as positive. And patients were randomized to second ARPI versus the lutetium. In this case, it was a crossover design. So if you crossed over the control arm, you'd have the ability to be treated with lutetium as part of the trial. Patients were predominantly treated with abiraterone, with enzalutamide kind of being a close second. And I'll simply say that there's a lot of patients here that are similar to what we use today. And some of these patients were treated with ARPI in the castrate-sensitive setting, some in castrate-resistant. But the bottom line is that they did much better when they got the lutetium. Here you can see the hazard ratio 0.43, which is obviously good. And it turns out that this led to the FDA approval. Here's the time to the PSA progression. Again, you see the positive outcome with lutetium. Hazard ratio here is in the 0.4 range. So this is clearly a positive trial, published in Lancet, now FDA approved. The survival was 0.91 for the hazard ratio with confidence intervals that overlapped 1. But please remember the crossover. 57% of the patients in the control arm crossed over to receive the lutetium, was 82.2% of those eligible. There was a crossover adjusted analysis, one called an IPCW, and I'm not a great statistician, but the crossover adjusted analysis came out positive for OS. Anyway, I'll simply say we have OS in the advanced setting. I think we'll probably have OS here if we designed the trial without crossover. But that's not the way it happened. But it did lead to the FDA approval. What about castrate-sensitive metastatic disease? I mean, that's sort of the next step. And now we have the PSMA addition fully accrued in 2024, reported at ESMO 2025 by Scott Tagawa as first author. I'm the co-first author on that manuscript. Actually, we just submitted the manuscript revision to Lancet, so we anticipate another Lancet article from this particular study. There's the RPFS, preliminary, relatively immature data, but nevertheless has a ratio of 0.72, confidence intervals not overlapping 1. I think that this will have a good chance of getting through the FDA. You have to see. The overall survival is still quite immature, but it was 0.84 for the OS. And that's kind of to be expected that there would be a positive trend, but we need more. Now, can we go even earlier? So I've kind of covered FDA approvals, castrate-resistant and kind of taxane exposed, castrate-resistant for those who are taxane naive, hormone-sensitive. Now we're going to drop back even further and talk about those who are PSMA PET positive and conventional imaging negative. So these patients don't even have a positive bone scan or CAT scan. They're just PSMA PET positive oligometastatic disease. And there's a trial called PSMA DC trial that we put together, asking the question, can we avoid the use of androgen deprivation in this setting? Now, there's a small trial put out by the group at UCLA called the LUNAR trial. And they basically did a similar study, but without putting together the endpoints that are FDA approvable, which is a little bit of a problem because you can't take this to the, well, they took it to the regulators and the regulators say, slap down, come back later. But on the other hand, the PSMA DC trial is designed with regulatory approval endpoints. Here you see a PSMA PFS here. This is PSMA PET scan, which is a non-regulatory approved endpoint. Hazard ratio was 0.37, showing that the addition of lutetium to SBRT to the oligometastatic lesions provides benefit in terms of time to progression. No androgen deprivation being used here. This is the PSMA DC trial. It's accruing quite nicely. It's almost halfway done. And it's an international trial looking at the oligometastatic PSMA PET positive space, avoiding the castration. Everybody gets SBRT to the oligometastatic lesions. Half of the patients, actually 2/3 of the patients, are going to be randomized. It says 1-to-1, but that's actually changed to 2-to-1. So 2-to-1 randomization with an MFS endpoint, metastasis-free survival here with conventional imaging, which the FDA has said, if you hit that endpoint, we'll give you the approval. So that's ongoing right now. One of the things that's a little bit interesting is most of what I presented is with lutetium, but it doesn't have to be lutetium. There are other isotopes that we can bring to the fore. One that's very interesting is called terbium-161, and there are significant trials going forth with terbium-161. And the terbium seems to be better on the single cell kill or the very small cell cluster kill, which is one of the shortcomings of lutetium. When you get smaller and smaller on the cellular scale, you have less and less effect. But that's with lutetium. As you change the isotope to terbium, you can do better. And also, if you change it to the alpha particles, you can do better yet again. What about synergistic opportunities? I think this is really important. So far what I've shown you is monotherapy. We just use lutetium without much else. We did in the vision trial, well, standard of care, but it was like whatever. You put in steroids or third-line RP or the choices of palliative radiation, whatever. But here we're beginning to look at things in more detail, particularly with DNA damage repair pathways. We believe, and most of the data is consistent, when you're using lutetium in the isotopes, it's really working by damaging the DNA in those cancer cells. And if you inhibit the repair of the DNA damage, it makes sense that you would be able to provide some degree of synergy. And the preliminary animal model data says that. There are PARP inhibitors, ATR inhibitors, ATM inhibitors, DNA, PK inhibitors, and more. All of these are being looked at in various experimental forms. But we have clinical data with the PARP inhibitors. It's a trial called the LuPARP trial, done in Australia with Janine Sandhu, who's a really excellent investigator down there. The PSA 90 responses are really good, 44%. It's a dose escalation trial, which she started very cautiously with the olaparib, which is an FDA-approved PARP inhibitor in prostate cancer. But these are patients without DNA repair defects. These are just all comers. And the bottom line is, she reported at ESMO this past year on the overall survival. This is out of a phase 1 trial. These are pretty heavily pretreated patients, kind of similar to Vision. Vision, the overall survival at median was about 15.3 months. Here, she's reporting median overall survival of 33 months, so it's like double, which really got my attention. It's quite good. And we're now playing around with this in the clinic. Problem is the PARP inhibitors are expensive. We don't always have access to them. But the preliminary data with the PARP plus lutetium is outstanding. So we need to pay attention to that. There's also preliminary data that the antigen release from radiated tumors may be important in activation of the immune system. And there's a little bit of data where you combine the single-dose lutetium followed by pembrolizumab and being able to show that the outcome, at least by PSA waterfall plot, is good. We still need randomized studies here, but some people believe that the immunotherapy combination with lutetium or other isotopes could be quite good. So we just need to get more data. Alpha particles. So what I've talked about so far are the beta particles, which are basically like little electrons. It turns out that alphas are basically a helium nucleus. They're 2 protons, 2 neutrons. They're about 7,000 times heavier than an electron, and they travel pretty fast. The electrons are going almost the speed of light, so they're flying off. Those beta particles are coming off the speed of light. Here we're talking about 6% of the speed of light, but it packs a fair amount of energy. It's like a little nuclear bomb going on. And it turns out that they don't go very far, so the alpha particles really only go microns as opposed to kind of millimeters for many of the betas. And they pack the wallop, and they cause a lot of DNA double-strand breaks, which are hard to repair. So a lot of people are putting alpha particles at the center of their strategy. There are 3 alphas that are chelatable and being used as astatine-211, lead-212, and actinium-225. Radium-223 is Xofigo, FDA approved, but it's non-chelatable, so we can't use it in the targeted alpha therapy that we want to. By the way, nice targeted alpha therapy conference in Brazil next month. We go down all the targeted alpha therapy people to down there. I get to go down there to Rio and enjoy part of that part of the world. This is, obviously a case report. It's not a clinical trial. But here's a person with a PSA of 2,900. They've gone through, every treatment you can imagine, except for the lutetium-177, go on actinium and get a complete remission. And, some of these patients have outstanding responses. So as we go forward, we need to pay attention to this. This is a provocative study from FK out of Pretoria, South Africa, and that's a PSA waterfall plot, just giving the actinium with no hormonal therapy. This is just actinium with no hormones, and you get that kind of PSA waterfall response. So people are excited about this. This is a ESMO 2025 presentation with Lead-212, a little company in Australia called Advanced Cell. They have a really good waterfall plot for phase 1, so they're now expanding this into phase 2 and thinking about phase 3. But Lead-212 is definitely an active agent, and it's an alpha particle. If we look at the current commercial programs with alphas, Convergent, which is small biotech up in Boston. AstraZeneca is about to launch a phase 3. Telix has got one underway. Bayer is planning a phase 3 with something called Trillium, just presented at the ASCO GU in San Francisco, 3 weeks ago, whenever it was. Novartis has 2 phase 3s that are already up and running. ITM is moving forward, one called Full Life is moving forward. ArtBio, Viewpoint, Advanced Cell all have Lead-212s. Another one, Astatine 211, is moving forward with a company called Z Alpha. So lots and lots and lots of commercial activity ongoing here. But the Novartis is in the lead with 2 phase 3s actually underway. So that's important. One of the things that's a little bit of a problem, and I talked about the way isotopes can overcome heterogeneity, and they can, but a lot of the cancers that are actually killing people are not even expressing PSMA at all. And this is a problem because if we don't target the cancer cell, we're not going to be able to come forth and benefit the patient. So this is an autopsy study at University of Washington in Seattle, and basically showing that even though PSMA is positive, it's not positive in all the patients. So we need more. So currently we're thinking about targets beyond PSMA, and there are a whole list of them here: B7H3, HK2. HK2 is also known as KLK2, kallikrein-2. And that's a really good target. J&J is targeting that with so-called pasritamig, which is their T-cell engager. Anyway, provocative data there. They're now in phase 3. STEAP1, STEAP2. STEAP1 is in phase 3 with the T-cell engager. STEAP2 is being explored by AstraZeneca with radiopharmaceutical. B7H3 is coming at from a couple of different angles. One called Mariana is about to go, and there's another one with Actis, AKTIS, that's going. DLL3, which is neuroendocrine, CKM5 is being looked at, HER3 is being looked at, GRPR is being looked at, TROP2. ACP3 is acid phosphatase, and that's a pretty good target. There's more than one company going after it, and BMS paid a bunch of money to get an ACP3 targeted agent through RayzeBio. They're going to be pushing that forward. FAP, which I didn't talk about, which is fibroblast-associated protein, is a stromal target. That's moving forward. And so is LRRC15, which is moving forward, another stromal target. So lots of stuff. And all of these can be imaged with PET or SPECT, and all of these are kind of targeted therapies. There's activity, both either preclinical or clinical, for all of these molecules right now. So what we're seeing now is the tip of the iceberg. Where do we go from here? Different targets taken in PSMA, yes, but also improving upon PSMA. I've seen a new PSMA ligand that is extremely attractive, probably could be able to beat Pluvicto. Different isotopes, both the actinium, the Lead-212, terbium-161, in addition to the lutetium. Lots of combinations, hormones and isotopes like the Enza-P trial, immunotherapy with the PD-1 inhibitors like Pembro, the pair inhibitors like the PARP inhibitors, radiation sensitizers, chemotherapies, all of these combos are moving forward now. Earlier stage of disease, like the PSMA-DC trial, the oligometastatic PSMA PET positive, and of course, all I've talked about is prostate, but every other cancer, whether it be ovarian or uterine or cervical or lung or GI, colon, pancreatic, there are programs just all over the place. So, watch this field. It's developing incredibly rapidly. And I'm predicting there'll be many FDA approvals in the years ahead. And with that, I'll simply say that one of the things that attracted me to this field is the ability to overcome the heterogeneity of the underlying cancer cells. If you look at the genetics, it's all over the map. We have everything from APC, mutations to BRCA mutations to mutations, EGFR, you name it. Mutations are all over the place. But radiation doesn't really care. Radiation can kill them all. It's not precise therapy, it's imprecise therapy, but can overcome the heterogeneity that we face in the patients we treat. And with that, I'll say thank you. Thank you very much, Pia. And enjoy it. I'm going to sit up here.